So here you are watching drug-induced sleep endoscopy with BIS monitoring. A 53-year-old male with apnea hypopnea index of 62 and body mass index of 24. So he's not obese and he has a apnea hypopnea index of 63. Now he's got a little deviated septum on the right hand side, as you can see here, and he has history of evident choking and snoring in the night. So we have anesthetized his nose with 4% xylocaine and adrenaline, and we have sedated him with dexmedetomidine. As I am passing through the nose, that's the nasopharynx. There are no adenoids. Salpingopharyngeal folds are not enlarged. They are grade 0 by A cross classification. And as we go further and look into the velum, you can see that there is only a partial collapse at this point of time. This is still anyways above 80. You can see the uvula is pretty long and the patient has started snoring already. Tongue base is not large, but right now we are waiting for the BIS to go below 80, and something between 70 to 80 will be the correct BIS. You can see that the uvula is pretty long. These are the tonsils. And we'll wait for the patient to get into the correct stage. So now we see the BIS coming down below 80. However, we still have to see apneas. We'll still wait. So we'll watch the movement of the structures when the patient is snoring. You can see that the tonsils are coming closer. The uvula is base of the uvula is moving behind. You still have to wait for some time. The palate is really quite long. The CT scan of the patient for the nose is relatively clear. There is no sinus disease. And his main obstruction is definitely at the palatal level. And here you can see the whole thing has started collapsing. The tonsils have come closer. This is the left tonsil going and touching the right tonsil. So this is a predominantly lateral type of collapse, but the uvula is really long and that's also contributing to the collapse. There is no tongue-based collapse. Now you see a complete apnea. That's the apnea. The tonsils are meeting completely with each other. So now the patient is in the correct this range, consistently below 80, still a little awake. Now his saturation is also reaching 92, 93. But even at this, you can see that there is no tongue base collapse, and this is majorly a palatal level collapse. So he will improve appreciably with a suspension bridge pharyngoplasty, in which will remove the tonsils, will take care of the soft palate, will not let it fall posteriorly, and obviously will take care of the lateral collapse as well. So both AP and lateral will be taken care of, and he will definitely improve with a palatal surgery. You can see that there is no tongue base collapse, though the epiglottis is a little narrow over here. But so far we have not seen the epiglottis completely choking, and at this point, yeah, this is the point when we see along with the soft palate, the epiglottis also contracting a little like a omega shape. So we might do a glossoepiglotopexy. Correct. This is the perfect stage. The palatal surgery along with a little bit of glossoepiglotopexy. So I'm going behind the uvula and see what is the how is the epiglottis looking. You can see the epiglottis now also contract. So this is the perfect stage. We'll have to do glossoepiglotopexy so that the epiglottis does not uh, you know, collapse after the palatal surgery is performed. This is the perfect stage for drug-induced sleep endoscopy. I was waiting for this stage for a long, long time. And with dexmedetomidine, you have to definitely get the perfect stage. You see that there is no tongue base collapse. Little bit of lymphoid tissue at the tongue base, which will be taken care of by glossoepiglotopexy along with the palatal surgery. The left tonsil is definitely much more obstructing than the right one. So bilateral tonsillectomy, uvulopalatopharyngoplasty by suspension bridge method, and glossoepiglotopexy for this palatal epiglottic collapse. Thank you very much for watching.